So they studied it actually for years in terms of that 4 millicurie fixed dose, and this is still very common out there. It's RadioCat, that's one shot, 4 millicuries. And they just run through them and they'll retreat them, but the owners have to then go through another week and then two weeks off. They're actually not around here, but that is what they've done, and it's worked well because they get 92 out of 100 cats treated. It's a volume thing. So everyone was looking at these, trying to determine why they weren't getting 100% treatment response, but in that they said, well, 92 to 94% is good enough. Let's just go with that, it makes it easy. But in people, they looked at why do people fail treatment? And they've looked at all these countries, and they've gone through, and they've all come up with the same 3 things. Call it a large goiter, large thyroid in people. The higher the T4, the higher probability of failure, and the inadequate dosing, so they couldn't afford to actually give them more. Those were the 3 things, yeah.
Why is there an only standard dosage? Why wouldn't you be able to give a certain amount to one pet?
You can. So what happened was the studies that were done early in the 90s, they did all of these different variables looking at it. And even after calculating and altering doses and everything, they ended up pretty much getting a 94% success. So they're like, we don't see any difference in terms of trying to figure out which dose to give them. They looked at body size, looked at breed, they looked at sex, they looked at T4 levels. It just didn't seem to matter on that. And so they said, well, we're just going to do the standard 4 millicuries because it doesn't matter. So, and I actually asked the same thing. So this was just one of the studies that was done in 2002, looking at the relationship between pre and post-treatment thyroxine levels. And they looked at that relationship on the thyroid to salivary. Can they use it to determine who's going to fail? There was no relationship between thyroid to salivary ratio and the thyroxine levels and the success at 1 week post-treatment or even long-term. They couldn't find a relationship to it. But I ended up actually a few years ago trying to figure out, well, why are we getting these failures? And if you go back to that thyroid scan that they were looking at and basing it off of, that saliva is not consistent. That alters, so you can't really use that to base therapy. You can use it to base if they're positive or not, but you can't use it to base therapy because that changes. But the thing that doesn't change is the blood pool, actually, the amount of technetium in their background. So that actually looked like it was more promising to determine and compare that to the thyroid and determine who's going to fail, because that one isn't affected at all by their swallowing. So we looked at the 153 cats we treated here, and we ended up coming up with a thyroid to background protocol on this. And let me see if we have the video. And it doesn't look like we have that. So what you end up doing is a area around the thyroid, and then this area here in the background, the blood pool. And what happens is 2 things. First is, because this thyroid's taking up more, the blood pool shrinks. Second thing is that this gets so hot that you get less counts in the periphery. And that's what adjusts this thyroid to background ratio. So this one was 5, that one was 11. When we ended up looking at who failed and who succeeded, the mean of the failures was almost 30. The mean of the successes was 8 on a thyroid to background. There were outliers. So you had some here, but the majority of them were down here, and the failures were higher in the thyroid to background ratio. Okay, so we changed our protocol from a 4 millicurie dose to a 4 and 7. Thyroid to background ratio of less than 11 gets 4. Greater than 11 gets 7. That's what we're getting for success over the last couple of years. 1 to 2% failure now. And I presented that, and actually a lot of people are now using that. They present to the ACVR, and a lot of people are starting to use that because that doesn't take into account the saliva, and we're getting it closer. Do we still have failures? Yeah, we still have failures. We actually, it looks like some of them are so big that they have to get a higher dose or a second dose than 7. That's the ones that are failing. We do have some other ones that fail, and we don't know why, that are in the normal, like a thyroid to background of 5 or 6, and it just doesn't take at all. Don't understand why.
Is it the bulk or non
It would improve it, because this is absolutely a volume thing. If you only give them 4 millicuries or even 7 millicuries and it's a big or multiple, there's not enough iodine in there to actually kill. So if you debulk it, then you can treat them with a lower dose and they have a better success. But you have to wait, because you have to wait for tissue healing, because that radiation that's coming out of that will actually then affect wound healing, and you don't want dehiscence. So it's a little bit there, but you're treating them afterwards. But I recommend debulking.
So is it safer to debulk and then iodine, or treat them twice?
Oh, that's an awesome question, because we've had some really big thyroids and we've had some disasters with them. In terms of, we've had one that was, and I'll talk about that in a minute, but we've had some down in ectopic that after treatment developed pleural effusion. Why? Probably because the thyroid was touching the pleura and then it ended up causing a pleuritis. Other ones, when it's so big and such a high dose, you can end up having esophageal problems going on there. And what we've done now to change that, and the other thing is that just in general, the big thyroids, and you give them this dose and you alter their homeostasis so quickly, they just go off food. They're already debilitated. They go off food. They do poorly. So what we've done now is, if they come in at all in terms of a concern or a really huge thyroid, we'll put an E-tube in them. We actually have one in there right now. I got an E-tube 2 days after treatment. There was no eating. The cat actually, we started doing the feedings immediately. Now day 3, the cat's perked up. They just don't have, if they stop eating, they're going downhill quickly. So if you can debulk them and it's going to be a whopping dose to try and take care of it, I'd say debulk it. I think so. But you can do the I-131, but there are complications when they get really big. So the other thing that people are asking on that is, does that increase the incidence of permanent hypothyroidism if you're giving them such a whopping dose? Turns out no. The ones that were hypothyroid permanently were actually these, because there's probably a level where their thyroid to background is lower and they need a lower dose. There's probably another tier. There's probably another tier below this and another tier above this in terms of that. These guys, they actually were going into the euthyroid state pretty much, because they were getting the right amount of dosage. So they get the 5-day staycation, and the 3 days of hotness is, that's that 3-day release. They really are. They're still hot. They're still excreting. And for this is why we do this money back guarantee on that with the owners, because we're getting to 1-2 failures out of 100. I don't mind retreating them and telling the owners, look, here's the bright line, here's the silver lining too if it fails. We're just going to retreat it, because one, it gives us more information. We find out why they're failing, and if it's constantly because it's really big, then we're going to be able to use that for research. If not, well, then something didn't take, and so I should have taken. So what we do for that guarantee is they either get $500 back or a free treatment, second free treatment.
How long do you have to wait in between treatments?
That depends really on what the values are coming back and how clinical the animal is. I used to actually wait, because I would wait a while. I would have told them that we would go 6, 8, 12 months out, because that's how long it can take. But now these cats are coming back. Over the last 3 years, the ones that are having any issues in terms of, we'll see them at 3 months, 6 months, still high, they're clinical. We'll do them sooner. We'll bring them back, and then we'll do a thyroid scan, and if they're hot, we'll just
Time you recommend tap treatment?
yeah, we do. If they're back clinical and their T4 is high, we'll put them back on tapazole.
Do you see an improvement, like on the ones that do fail, do you see an improvement in their thyroidism, like moderately, like they're not cured, but they're better?
Transiently. And sometimes we'll have them pop down into the normal and come back up. So they just, some reason it didn't take. I don't know why. The crazy thing about this, and this is the weirdest thing, is that the failures on there, these right here, I think there were 3 or 4, something like that in that level. Over 2 years, all of them were in June or July. I don't know what the hell that means. It was 2006, 2007, but it was June or July. I don't know if there's someone in the lab goes on vacation and the janitor steps in. I don't know what's going on, but something's different. I asked them, they won't tell me. So post-treatment, what to expect for the owner? 2 weeks of limited contact, because we want them not to be exposed to radiation. They can have 20 minutes per day. If they sleep with the cat, that's a no-no. We're not having that. They have to put the cat away somewhere so the cat's not on their head. Follow-up blood work. This is done through you. We recommend a post I-131 blood work at 1, 3, 6, 12 months. At this one is when you're going to see the stabilization, where they are with their B1 and creatinine, where they're going to be. At 3 and 6, if you start to see their thyroid dipping, staying low, start talking to them about supplementation. I know it sucks and they don't want to do it because they didn't have to do a pill, but you got to kind of say to them, look, low thyroid on this, it's either this supplement or you're going to end up dealing with renal disease. For the cat, GFR decreases and stabilizes at 1 month. Okay, we talked about that. The risk of hypothyroidism is more common with bilateral disease, so we talk to owners about that. If they really are worried about it, say, look, the cat's unilateral, it's a low chance because you're not affecting both of them. The one goes away, the other one rebounds. If they're both hyperthyroid, you're going to kill both of the tissue and they're collateral damage. So you kill the entire thyroid. What we'll see is that they will go down for 3 months. It's very typical to see them have a nadir about 3 months and pop back up at 6 months. If it's 6 months, I start talking about supplementation. They're still low. Okay? There is a small percentage of recurrence. It doesn't always have to be at the same site. It can be elsewhere. It's usually about 2 years post. This is the one where there's renal insufficiency post. They have hypertension beforehand. That actually might resolve. It's really the ones that afterwards have a little bit of reduced GFR, underlying renal disease. You need to check them afterwards for hypertension because that's when they're going to be more common to have that. And the cardiac changes may or may not change. They may progress. They may get better. We had one cat that had a really big thyroid that developed a severe anemia. Thing is, cat lifespan, red blood cell, I think is 60 to 90 days. Is that about right? Is it 120? Somewhere in there. It was like 2 to 4 months. This cat developed severe anemia within 2 weeks after treatment. It couldn't have been due to a lack of bone marrow production. So, but it wasn't, the bilirubin didn't go up at all. I don't know where these red blood cells were going, and the bone marrow, it couldn't have been affected by the radiation. And that cat did not make it. It did poorly. The owners did a lot, but that cat didn't do well. So we have seen, after treatment, one of these, and I think, again, I don't know for sure, but I think that's the ectopic tissue in the mediastinum causing the pleural effusion because of pleuritis. So there are things that can happen, and it's really with the bigger masses. So debulking is a good idea sometimes. Contrast CT prior to treatment, no. If you have to do it, then it's 60 days. But you can wait. If you do a thyroid scan, if you need to do a CT, you can do the CT with contrast, and then 24 hours later or after that, you can actually do a thyroid scan. It doesn't affect it.